Hi, everyone, and welcome back to our next episode of ReWalk's Topics in Rehabilitation webcast. I'm Kathleen O'Donnell, and today we'll be talking with one of our own therapists here at ReWalk, Jill Butler. Prior to joining us here at ReWalk, Jill has had over 10 years of experience as a practicing physical therapist and is a certified neurologic clinical specialist. Her talk today will focus on some of the clinical problem solving and advanced practice techniques that she has developed to help support therapists to train their SCI patients with exoskeletons and discharge successfully to the community. Hi, Jill. It's great to talk with you today.
Hi, thanks. Great to be here. I'm excited to do this. So I'm just going to go ahead and share my screen real quick and we'll hop right into it. Excited to be talking about this topic. I think it's something that our currently trained ReWalk therapists will find really helpful and be able to incorporate right away into their own clinical practice with these patients. So we'll jump right in. Our objectives today are essentially to provide a supplemental resource for those currently trained ReWalk therapists, just to help to advance your skills and integrating the ReWalk into the home and community from the rehab setting. We're gonna do that by discussing some clinical problem solving using a few case examples with patients who are currently successful home users now. We'll review these examples and go into specifics about skill progression, session customization, and most importantly, discharge planning. We're going to take all that and sort of bring it to use. So we've been using the ReWalk in the rehab setting, and I know most of you are probably pretty comfortable with that piece of it at this point. But what we want to talk about here is really getting even more comfortable with getting patients started in the early phases of their rehab, and also with progressing them to getting it actually into the community. So our first case is going to be an early training scenario where someone's just getting started with their walking. And then our second case will go into transitioning patients and ReWalkers into the actual home and community. For each case, we'll break it down and sort of show you things that the therapist can do, the patient can do, the software or hardware can do, and supplemental supports can do to help along this process. Our first case is a gentleman named Tim. So he's a 27-year-old Navy vet who sustained a T4 complete SCI 7 years ago. He has recently been cleared to pursue the ReWalk for home use through the VA, and these are some of his early training sessions. So as you can see, he is making some progress, but his PT feels like they're working really hard. The patient report's feeling pretty anxious about it. And so they reach out for some support and report that he's struggling to find his balance in his home position, just in standing, to initiate steps, and also to avoid unwanted stops once they do get going. So you can see here that sort of his crutching is pretty inconsistent. A lot of movement up top in the trunk there, and the PT is working decently hard. So the first thing we're going to talk about are things that a therapist could do. So this video is here to highlight good guarding techniques. So you can see here, this therapist is making sure that she's standing close to the patient. Okay, she's using a wide base of support. You can see her arm placement. They're at sort of 90-degree elbows, really close in by her side. She's using her own body weight to shift and facilitate the patient's weight shift. Okay, she's not using her arms to try to sort of throw him around. One last thing to note is that your swing phase should not match the patient's. Okay, you want to maintain your own double limb support for a little bit longer than usual. Okay, so sort of delay your swing phase and try to have it be off from when the patient is swinging. So what the patient can do in the early phases of training really is to focus on their crutch timing and their upright trunk posture. So this patient is doing a really great job here. What he's doing is moving those crutches just about a few inches beyond each heel strike, really consistent, both crutches at the same time. Okay, he's leaving them on the ground for really as long as possible, and then just right as that heel strike is about to occur, both crutches go together just a few inches ahead. Okay, and he's doing a great job keeping that chin high, chest tall, as little trunk movement as possible. Okay, so in terms of supplemental supports that you can use during this earlier phases to help patients are potentially either just a abdominal binder or something all the way up to a supportive of something like this Aspen Vista that we're seeing here, full-on TLSO. So depending on the level of injury, patients with impaired upper trunk control, the use of something just to give them a little bit of static support and potentially just tactile feedback as well can go a really long way to helping them in the initial phases anyways. And sometimes some patients will use it throughout their usage with the ReWalk, but especially early on to help patients while they're not maybe as coordinated as they're going to be with the crutching and whatnot. Something like this can definitely help. And then some of the tools that you're used to using just for patients that you would do standing balance activities with. So visual feedback with either mirrors or taking pictures or videos of the patients while they're trying to work on just their standing balance or even their walking posture can go a really long way. As we know, these patients have obviously impaired sensory feedback. And so using their visual system is something that can really help if you find that your verbal and tactile cues aren't going as far as you'd like them to. In terms of the hardware and optimizing the setup, we want to just focus on some ankle settings in this phase. So we want to make sure that we're only setting the ankle joint to the amount of range of motion that the patients have available at their ankles. Okay, if we're setting it to anything beyond that, dorsiflexion-wise, they're going to feel a pull and they're going to experience that potentially as sensing that their balance is being pulled off. It's usually going to feel like they're being pulled forward. If we're setting them in more dorsiflexion than they have available, their body's going to compensate by bringing everything forward because they don't have the muscular length or joint mobility to achieve that level of range of motion. So just make sure and back off on that front part of the ankle joint. So open up that dorsiflexion stop as needed to accommodate for lack of dorsiflexion range. As they stand and walk on the device, they often get better range there. So definitely circle back to that, however, as they get going, because the more anatomic position we can get them in, which obviously is some dorsiflexion, especially in late stance phase, the better. So as they progress, circle back to this and sort of bring them down into more dorsiflexion. But early on, open them up, and that can surprisingly sort of help a lot with their standing balance. And then the other thing is the other side of the ankle joint is the spring for dorsiflexion assist. And really, we just want to avoid overly loading the spring here, again, especially early on. It can have a similar effect of just feeling that the patients can report that it's really sort of throwing their whole system in one way or the other if you have it cranked down too hard. So keep it right in a light range usually early on. Okay, and then last thing we'll talk about are the software settings. So this is a gentleman who is in the earlier phases of his walking, and that looks decent, right? His crutching's okay. They brought me in though because they felt like he was having a hard time progressing from here. The therapists felt like they were having a hard time getting away from sort of meniscus. He was continually sort of needing their help for just a little bit of balance each step. So what we recommended is a few things really. We ended up decreasing the delay between steps and the step time. So both of those together will result in the device going a little bit faster for the patient. Once they get the hang of the crutch placement and the weight shifting, having the device go too slowly will actually cause them to struggle with their balance and their upper trunk sometimes. So what I recommended and what we did with this patient was essentially just to speed him up. So we decreased the delay between the steps and we decreased the step time or swing phase time. And so you can see on the video on the right, it really smoothed things out speed-wise to the point that he actually broke into a reciprocal gait pattern there with the crutches independently, which was pretty cool to see. We also, it's subtle, but we also, if you look closely, did increase his hip flexion angle and decrease his knee flexion angle. Okay, essentially, as patients progress, we're just working to get them to the most anatomic positions as possible. So early on, we want a smaller degree of hip flexion, so it's shorter step lengths, easier to manage. But he's a tall kid. As we got going, we wanted to increase that hip flexion and then smooth out the knee flexion just to, again, anatomic ranges. And he got feeling much better. The therapist, so now you can see he's just hovering his hands over the back. They were sort of contact guard by the time we finished that session. Okay, so moving on to our second case. This is a user who's a little bit more advanced at this point, as you can see from this cool video of him cruising outdoors. So Kevin is a 43-year-old male who sustained a T8 level of injury, complete STI, 4 years ago. He trialed the ReWalk at a private freestanding clinic down in Georgia, achieved coverage through his insurance, and began training. Initially, he had poor trunk control, but with the addition of an abdominal binder, some targeted crutch placement work, and some balance and seated trunk control work, he saw some really exciting progress. After 20 visits, however, he began to feel that he had sort of reached his max potential and that he would always need the help from a PT. His PT, however, knows that he can be successful at home, but just doesn't know how to help him achieve that, and so they reached out for support. Okay, so in the more advanced phases of training, what can the therapist do? Really, planning is key. So just like in any other physical therapy plan of care, you want to start early and work with the patients to plan how they're going to carry over what they do with you at home. So really within the first few visits, you want to work with both the patient and their companions to develop a realistic and specific discharge or usage plan. You want to then use that plan every session to guide activity selection, keep them motivated, keep everybody accountable, track progress, and really just significantly increase the likelihood of them using it at home. There are a few little obstacles that need to be overcome in terms of just figuring out where they're going to use it, how they're going to use it, and by just tackling these early on and getting things into place, it can just really increase everyone's confidence and help them reach that ultimate end goal. And then the other thing really that the therapist can do is to let them fly. And this is something that anybody who's used to working with gait training and with neurologically impaired patients, it's a struggle. And it's something that our instincts tell us to hold people close, right? And so as a patient gets into the more advanced phases, however, and they're really consistent with their crutching, especially with their sort of balance recovery with their crutching. So if you've been working on their standing balance with their crutching, you got to start just guarding them with loose fingers or even letting your hands hover lightly over the uprights or the pelvic band to allow the patient to gain some valuable balance experience. Okay, so just like any other patient that you're doing gait training work with, if you don't ever allow them to sort of have a little bit of failure with their balance, they're never gonna learn to have those balance recoveries on their own. So when you're confident in their crutching, you don't have to go from hands-on to nothing, just really light grip or just a slight hover. So you're definitely there for them, but you're allowing them to sort of grow and then fly. Another thing that you can do as a therapist is to help them connect with sort of the world of ReWalkers. This is something as a company we try to help them with as well. And as we're working with patients, we do introduce them to Facebook groups in their areas and different things, but know that there's a growing community of ReWalkers worldwide, and having the support of another. This is a really great story that was broadcast on the BBC of a sort of a veteran ReWalker helping a new ReWalker have the confidence to sort of try and take it to the next step of actually walking with it outdoors and almost hands off. You can see that her therapist behind her is definitely hovering, doing the hovering technique that we had just talked about. So definitely encourage social connections for your patient to meet, be inspired by, and definitely learn from other ReWalkers in their community. So things we can think about to optimize setup in the more advanced phases of training. Moving the front knee bracket, so hardware-wise, so that's the bracket that's just below the patella on the tibial sort of plateau, tibial tuberosity there. So as we talked about that over time, their ankle range of motion we'll see here, mentions it, I mentioned it earlier, as their range of motion in general increases, we want to just get to the most physiologic position as possible. So early on, they might have needed to have those knee brackets positioned a little bit anteriorly to allow for some knee flexion for tightness either at the gastroc or the knee joint directly. But as they progress, they likely have gained this range back. And so we want to be constantly assessing, potentially move those brackets to a more posterior position that will encourage a little bit more upright anatomic positioning. As I mentioned, the dorsiflexion stop, so increasing that, especially if they're having a tough time with ramp navigation, but just in general, in the advanced phases, you want to increase the range to as most anatomic position as you can. Just ensuring in general that the fit is still good, right? So again, these patients are going to experience a lot of physiologic changes from training in the ReWalk. Even after sort of a short time, they potentially are going to notice changes in their weight a little bit, their body sort of mass. So their pelvic band, potentially they could be ready for a smaller size pelvic band. Strapping could change. So just be always assessing. Software setting wise, we want to think about decreasing the walk current threshold. Okay, so that is the setting in the software that tells the device when to stop essentially and return to stand mode from walk mode. Early on, we want this to be turned up pretty high. We want that to be a high threshold so that the patient has a lot of leeway when they're learning initially how to weight shift and manage their crutches for success with reciprocal stepping. But once they've sort of gotten the hang of it and they're ready to start learning how to stop on their own, and we're doing advanced skill training, you want to bring that current down so that when they do purposefully make the movements necessary to scuff the foot and stop the device, the threshold is set at a level that recognizes that as a purposeful scuff and returns them to standing as they're trying to do. Okay, if we leave that current up too high while we're trying to train them to stop the device might think, oops, that was an accidental scuff, I'll let them keep going. Okay, so we want to bring that threshold down as the user is becoming more advanced. And as we mentioned in the last case, continue just to decrease knee flexion and increase hip flexion as is appropriate for the patient's height, ability level, and comfort. What the patient can do, the first three things are something that you're going to have to really sort of help them with, but essentially visit length and frequency. You want to get them in there sort of hot and heavy if you can, for patients who can only make it in once per week or once every 2 weeks, just obviously there's a harder time gaining traction. So if you can get them in there twice per week, ideally, that would be great. Engage at least, we need to have at least one companion, but we found that potentially having 2 or 3, just engage the patient's whole sort of like immediate circle if you can in the process. The more people who are on board and understand and sort of aren't intimidated by the device, the better luck they're going to have in really successfully taking this home and out into the community. If it's all just sort of like on the one companion, that is great, and some people have a hard time even finding that maybe. So one companion definitely can work. But we found that if they have a few others, just even, close friends or things who are willing, then that can help them use it out in the community a little bit more than just sort of being on maybe one parent or something like that. And then again, with the setting and tracking activity goals, just like anything else these days, we all need to be held accountable. We all have sort of the devices and the widgets and things to do it. So encourage them to, step goals or activity ring based on it, or just anything really to engage them in actually using and tracking their device. The last thing we'll talk about here, we'll watch this video, is reciprocal crutching. So I mentioned that in the last video, the gentleman who, when we sped him up to a more comfortable speed and a more comfortable hip knee flexion range, really started cruising into reciprocal crutching. So 2 things with the reciprocal crutching. When someone is in that position where they're comfortable with their step length and with their speed, it can just, again, make for a more natural pattern. When we're naturally walking, our arms swing reciprocally. Something else to consider, though, is for those patients who are maybe struggling with full independence because of trunk control issues, the reciprocal crutching can be especially helpful, as it decreases the amount of time that they have sort of no upper extremity support. So although we do definitely encourage that sort of bilateral crutch movement symmetrically early on, it does require sort of a millisecond or so of time where they have absolutely no support from their upper body. So if you're noticing that your patients are every single step really collapsing as they're moving the crutches, they might be someone who you take the time and try to work with reciprocal crutching earlier than might happen naturally. It can be a difficult thing to sort of train, say like verbally, so it can be a little bit frustrating for the patient early on. Reciprocal crutching happens best when it happens naturally, as you sort of saw in these cases. But we've also found that if patients are struggling with the upper trunk, take the time and sort of just set their expectations that it's going to be a little bit tough to figure it out maybe early on, but once they get the hang of it, it's a light bulb moment for a lot of patients, and they're like, oh, and they feel that much more secure that they sort of always have at least one crutch on the ground. It's like learning a new dance move, though. Sometimes patients can get a little bit frustrated with themselves of sort of going same arm as foot or something like that early on, and so encourage them that they can try, a few symmetrical crutching. So once they get started, get going in a walking flow with crutching together. Okay, and then think about leaving one behind and focus on the one advancing crutch. And just expect that it'll take a few tries, but it can be worth it. Okay, last thing that we're going to chat about is transporting. So in terms of supplemental support in this advanced stage, we want to look at things that are going to help the patients have success with moving the device around. And so this is an advanced user over in the UK who does an amazing job of sort of whipping his device around. We recommend having an upright dolly, which you can see on the left there. You just secure with a bungee. Patients can do that themselves. Generally, just use the watch to stand the device up and strap it right on. And then the picture on the right is of a lightweight foldable bench. Okay, so for safety and portability, wherever you need to go, you should have these two items, and that will help you transport and then use the device wherever you want to do so. So we're going to wrap up here, and it's a little bit of a longer video, but we'll just let it sort of roll as I'm wrapping up and thinking we'll have some questions and answers coming up after this. But this is an advanced ReWalker who helps us out at trade shows sometimes and has really been with us from the beginning, but he is definitely a pioneer and has showed us how it can be done. And so what you see here is Andre just making it look so easy, but truly the point being is that once you have the tools, just like anything else, and the knowledge of how to do it, it is possible. We found that showing patients this videos, this is available on ReWalk's YouTube page. This can be a really inspiring thing for patients to see, whether it be early on in their training or if they're getting sort of frustrated, thinking that they're never going to be able to do this, if they're in that type phase. Just seeing the look on his face and just seeing him sort of manage this I've seen it sort of light up a lot of patients' eyes in terms of, wow, if he can do that, why can't I? And so that's just one way to do it. He folded his into sitting there. We've seen other people keep it in the standing position and just slide it right in the car, but you just got to work with them, go to their car. You want to just see what they have to work with and work with them to make it happen. It can be very flexible, and essentially you can bring it with you wherever you want it to be. So this is a veteran participating in the flag ceremony, actually at Walt Disney. So she's on Cobblestone, Walt Disney World, just cruising around. So the device can change lives. It can keep these patients healthy over time, and we can help them make this a part of their lifetime routine. So we'll end there. We'll do a few questions, and I just would love to encourage everyone to not hesitate to reach out to your local ReWalk representative. for any follow-up or questions about this. We just really want to be here to support you guys and our ReWalkers.
Thanks, Jill. And that was really great. I'm sure that's really helpful for a lot of our therapists who are, troubleshooting challenges of their own. We do have a couple quick questions to go through. One of the things that you mentioned was that supplemental trunk support can be a great option for some of the patients that you've seen. And I was just curious, in your experience, what percentage of these patients would you estimate could benefit from some type of supplemental support?
So that's an obviously difficult but great question. I don't feel like I could put a number on it per se, but what I will say about it is that it's a lot more than I would have expected or anticipated when I first started working with this technology. I was expecting for something so static to not provide as much support, especially early on. And so I think that I was thinking of it more of like a structural support. And I was like, so how could that really provide that much more assistance? But what I've realized in doing it, especially in patients whose level of sensation, the device comes about to mid-chest, sort of like T4-ish level, maybe T6, just depending on how tall the person is. So especially in those whose level of sensation is impaired at a level that below where the device hits, so they have no level of intact sensation at device locations. Those especially are patients who early on, they have a hard time learning the device because they truly can't feel it at all. And so maybe some patients who you wouldn't have thought really could benefit from the TLSO or just a binder, by having just really anything touch their body in a place where they can feel it, just for a few early visits, can help them get that feeling of shifting the device and feeling what it feels like to interact with the device. And then they might graduate out of it. So I think the takeaway point is consider it for a wide range of people who you see struggling with trunk support and with weight shifting early on.
Right. You also talked about the importance of creating a discharge plan and doing so early and revisiting it often. What are some of the key elements that you would recommend therapists include in this discharge planning?
So definitely identifying their companion or companions early on. And I would start with a broad pool there. So as many people as they can think about, just even friends, people that they just tend to hang out with the most often, sort of start thinking about that early on. And then really within the first few visits, you want to start getting those people in. So companion involvement early is in just identifying who that's going to be, any potential barriers that each individual might have, and sort of working through those and really thinking through who actually, once real life kicks in, or is going to be able to be there, not only just with training, but going forward for using the device. And then the other thing I would say is the logistics of sort of storage, charging, like where exactly in their house they're going to have it rest, have it charge, and where exactly they plan to walk in it. So you don't want that to be vague. You want that to be really specific of my driveway, the mall, this particular mall, or whatever it might be. What equipment they're going to use, and making sure that you help them obtain that equipment for transport. So like which dolly, which bench, those two things specifically, what shoes they'll put on it. And then the last thing I would say is, just like any other home exercise program, is the specifics of your recommendations for sort of frequency, duration, dosage of using the device. So once you sort of see what they can do by the end of the training period, you should have a grasp on what's realistic and what would be good for them. And so really not leaving that vague, but really just laying out, it should be whatever you've been doing in therapy, essentially a couple times per week for, a half hour or 60 minutes or so.
You also mentioned that the hardware and software settings may potentially need to be updated as the patient's status evolves. But in your opinion, what would you recommend that would be a good time frame for patients to be reevaluated following the discharge with the device?
That's a great question. And so that's something that I think, obviously vary patient to patient, but I would say on average about like a yearly checkup is probably ideal, and that is not just for the robotic technology. I mean, I think that as a treating clinician with the neurologic population, that was something that I always advocated with my patients. And obviously insurances and different things will come into play here, but in an ideal world, I think have once a neurologic condition is either diagnosed or injury sustained, I think a yearly check-in with a therapist just for home exercise upgrade, for equipment check-in, is appropriate in most cases. And I think that with the robotic technology, that just goes hand in hand right along with that. And so it might be a matter of, oh, I could use this new strap here. I've lost some weight. Let's look at the fit of things, or I've gained some weight. It could be a service need that they didn't reach out directly to ReWalk for. So the patients do know they can reach out and should reach out directly to ReWalk service if they have any device-related needs. But a yearly checkup could just help with all those things. And then also, like, as you mentioned, the software settings. And if they've gained a little bit more experience and they decide they want to go faster, we could try changing the speeds and mess around with sort of some of the software settings to meet whatever the patient's current goals are.
And lastly, for any therapists who are watching this and may have questions or need help problem solving any issues with their own patients, what is the best way for them to get in touch with you or another ReWalk representative?
So hopefully you still have a relationship with a local representative. So your training manager or your BDM, so your service manager. You can reach out directly to anyone you have a relationship with. You can reach out via our website. So just rewalk.com, there is a contact page. And that can just, if you have general questions, that will help direct you to us, and then we can assign the appropriate person to sort of reach back out to you. I would say those are probably the two best methods.
Yep. And that link that Jill just mentioned to our contact page is going to be in the description listed below for anybody that has any additional questions. So with that, Jill, thank you so much for your time. And to our viewers, we hope that you will tune in again with us next week, and have a great week, everyone.